as far as his work and his background. So Dr. Bill Moran graduated from medical school and completed a residency training in internal medicine at Georgetown University. While serving 4 years in the National Health Service Corps, he practiced full-time at a community health center affiliated with the Boston Center Hospital and the Boston Medical Center. He completed a geriatrics fellowship and served and received an MS in clinical epidemiology from Wake Forest, and that was in 1992. After joining the faculty at Wake Forest, he was a Robert Wood Johnson Faculty Scholar and served as the Residency Program Associate Director for Primary Care. In 1997, he became the Chief of General Internal Medicine at Wake Forest School of Medicine and co-directed the Center for Health Service Research and Quality. For 4 years, he served as the Clinical Director for the Northwest Region of Community Care of North Carolina. In 2005, he joined the faculty here at MUSC as a Magnight Professor on Aging and the Director of the Division of General Internal Medicine and Geriatrics. In his early research, his early clinical and research focus was on geriatrics and preventive care in aging and chronic illness management. More recently, his work has centered on local health systems changes which support physician decision-making in clinical practice, as well as facilitate interdisciplinary care and improve quality of care. The main area of focus is analyzing clinical environments, coordination of the clinical teams, and informatics infrastructure for the patient-centered medical home. On a national level, he served as the immediate past president of the Society of General Internal Medicine and has served as the president for the Association of Chiefs of General Internal Medicine and ACLGIM, and also a counsel for both of those societies in which he served. He also served as a fellow of the American College of Physicians. So I may be introducing to some, but and also presenting to others, Dr. Bill Moran. Thank you for coming.
Thank you. Boy, that was a long introduction. That means I'm old. Well, thanks for having me. I don't know whether I need this microphone. Maybe not. Do I need for recording reasons or anything? Everybody okay hearing me? Okay, great. So, this has been a fun journey, the patient-centered medical home. This is the way we used to practice medicine. Hendersonville, South Carolina, 1930s, just after the Depression. We, in some ways, haven't really come that far from there, but in other ways, we're like moving incredibly fast. This is actually what's driving it. So this is from 2000 to 2010. On the bottom, you'll see, oh, sorry. Yeah, sort of go back. Okay, so on the bottom is basically real wage growth, inflation, and medical inflation, 114% over 10 years, and the cost to workers and families of healthcare. So in 2003, only one state was the percent of household income 20% or more that's allocated to healthcare. So in West Virginia in 2003, 20% of median household income was going to healthcare. And now I'm getting it. 2011, only 14 states were less than 20% of median household income. So we are transferring all those costs to people and families. And about 1/3 of this is estimated by either the Congressional Budget Office or the Institute of Medicine is wasted. So we're wasting approximately $1 trillion a year in healthcare expenditures. Or the IOM said, well, those expenditures don't add value to patient care. The Congressional Budget Office is pretty straightforward. They say it's waste. So the question is, can we move more to primary prevention and move farther out from sort of spending a whole lot of money on sort of a small segment of the population? And we all know much of this expenditure does not actually improve patient care and doesn't improve patient quality of life. So that's one of the goals of sort of healthcare reform. There's other goals. So these are general statistics. RAND says Americans get evidence-based care only about half the time. Institute of Medicine says we probably contribute to the death of about 98,000 patients a year with avoidable errors in hospitals. CDC says we give 2 million patients an infection every year, 90,000 die. And the World Health Organization rates our healthcare 37th in the world. So the quality's not great. And part of the challenge has been the workforce. And in many ways, we see the payment methodology of pre-healthcare reform distorting the workforce. So this is, for example, all physicians over time, so 1960 to 2050. This is not a primary care physician. This is APPs, not primary care APPs. And then the box is the projected workforce for primary care physicians and advanced practice providers. And so what you see is we have this sort of huge specialization, and it's not meeting needs. So in 2007, 4 organizations got together: AAFP, Family Medicine, AAP, Pediatrics, the American College of Physicians, which is the internist, and the American Osteopathic Association. They don't agree on a lot of things, but in 2007 they agreed on these principles. Personal care physician and ongoing relationship with every patient. Now, that's 2007. It's now personal care provider as in an ongoing relationship. Medical practice in teams, a whole person orientation. You can't have a patient-centered medical home for like the left lobe of the liver or, the skin. Care is coordinated and integrated. Prevention, quality, and safety are hallmarks, so there's a big focus on quality of care. Enhanced access to care, which is incredibly important. And then payment appropriately changes to not be sort of very focused on procedural medicine. And then in 2010, the Patient Protection Affordable Care Act, also known as the ACA, passed. And it had a lot of things in it. It was very long. Insurance reform, workforce changes, a focus on quality, reimbursement shifting from volume-based payment, that is, if I see a patient, I get paid, to value-based payment. If I see a patient and I add value, or if I add value, no matter how I achieve it, then payment is reoriented. And then there's 3 basic new delivery system elements. The Accountable Care Organization, which we'll talk about briefly at the end, bundled payments. And a good example of bundled payments is if you need a total hip replacement, we used to pay for the hospital, we used to pay for the physician, there was no coordination. Bundled payments are, you guys figured out we're going to give you this much to replace that hip. And then patient-centered medical home, which is a new primary care delivery system. So, how are we measured? If we're moving from volume to value, Don Berwick, who was actually briefly the head of CMS until he was what's called an interim appointment, and then he was sort of kicked out by Congress. But he talks about moving from volume to value in terms of the triple aim. And the triple aim is a better healthcare experience for patients, higher quality and better population health, and lower cost. So that's the triple aim. Nowhere is there volume, sort of more services, more procedures. So you have to add value, you have to reduce the cost so that's higher quality and lower cost, and the patient should have a better experience of healthcare. And we all know of sort of the challenges patients face in accessing services. So about 4.5 years ago, we were first certified as a patient-centered medical home. And I just sort of wanted to walk through our process, how we did this, and then sort of show you a little bit about the outcomes we've had. But the first thing we did was we had to build a leadership team. And next, work on population. So these are the sort of 5 building blocks. Building clinical teams, re-engineering our microsystem, and building an analytic team to figure out how we were doing. So our leadership team is an interprofessional leadership team. We have Sarah Ball, who's a PharmD, is the project director, Kim Davis, who's a physician, and Alicia, who's the residency program director. Our nursing director, Kristen Powers. We have 2 lead nurses. We have a PharmD. We have an analytic team, and we have an outreach coordinator. And we've actually recently added an LPN. And as soon as we have a critical mass of APPs, we'll add an APP. So all the disciplines are represented. We meet every week. This group gets together. we work through specific issues, and we get everyone's perspective. So 4 years in development, we've had some early wins, we've had some incremental gains, and I'll talk a little bit about sickle cell PCMH. We've used a PDSA strategy of sort of testing methodologies. I'll give you an example. Let's send a letter to the 80 patients of this doc and encourage them to come in and get preventive services and follow up in a month. Well, in a month, nothing had changed. So we went back and said, did you get that letter? And the patient said, no, I don't remember ever getting a letter. Okay, well, that was a failure. Let's try something different, right? So you've got to do these PDSA cycles. You can't assume what you're doing is working. So we had some backsliding too. We are not in a capitated system. We are still in a volume-driven, fee-for-service medicine driven system. But one of the things that we found when we sort of worked with the hospital was the hospital actually runs very close to full. And so they actually work with us to reduce admissions. Now, if I were working at some of the other regional hospitals, that's the last thing you would want to do, is reduce admissions, because we're still under volume-driven fee-for-service. But here, we need the beds. And so us preventing patients from going to the emergency department or getting hospitalized is actually a good thing. Because I'm absolutely certain that Pat Colley would rather not sort of manage a COPD exacerbation that could have been prevented when he could do a total hip replacement or a kidney transplant or some other tertiary service that we offer. And so we got a grant from the hospital to sort of do this transition, and part of it was we really don't want preventable hospitalizations or preventable ED visits. We're already sort of running full. And then we had to hardwire the process. And this is sort of an ongoing process. So the first step is like, who do we care for? How to sort of characterize our population for us. And so we looked at sort of our practice. We have a faculty practice, takes care of roughly 6,000 patients, because none of these guys work full-time. A resident practice that cares for about 6,000 patients, none of them work full-time. And then we do about 38,000 visits per year through the 8th floor Rutledge Tower. And so the entire 8th floor is our medical home. And we have systematic discontinuity. 96 residents, internal medicine residents trained in the clinic, they do 1 block month every 4 months. So if a patient needs a doctor, the day after your resident goes off the rotation, they're going to see somebody else. So we had to build teams. And you'll see a little bit of that. So this is our demographics. It's actually an older population than the average age in the United States is about 35. We're at 58.6. We have actually a relatively nice distribution of young folks to older folks. 37% male, 51% white, and 46.2% married. So it's a relatively balanced and diverse population. This is the distribution of disease, or diseases, or coded diseases. So in the sort of 12,000 patients, roughly, the number changes depending on the criteria. We have over half of them have hypertension. Next is hyperlipidemia, obesity, uncomplicated diabetes, 2,600, all the way down to HIV, dementia, and sickle cell. And so we have a huge distribution of conditions within University of Internal Medicine, and that's actually what internal medicine does. So it's not unusual, but it's a pretty sick population. So we also started looking at utilization. And so we went retrospectively worked with the hospital to figure out how many of our patients have been in the emergency department or hospitalized in the last 3 years. And these numbers were astounding. 21,000 emergency department visits of our patients in 3 years. The max was 222 ED visits. Unbelievable, right? Not surprisingly, this is a sickle cell patient. Hospitalizations, almost 10,000. 41 hospitalizations. Again, this is a sickle cell patient. And then rehospitalizations, 2,100 in 3 years, and 28 rehospitalizations, a sickle cell patient. So these data started jumping off the page. And this is millions of dollars in utilization. So we started trying to figure out, well, how do we stratify risk? Risk stratification is actually well known. Generally speaking, it's risk stratified based on disease. And one of the challenges in our population is nobody has one disease. They have 3 diseases. They have hypertension, hyperlipidemia, diabetes, and probably some chronic kidney disease. Well, so if you do a disease-specific risk stratification, those are going to be 4 different groups. So we use a clustering methodology, which actually helped us understand more what our patient population is like. And so if you think about all the patients in UIM, all of them have kind of different conditions. What you can do is sort of statistically segment them out. This is just 5 groups. We segment out either to 8 or 12 populations. And then what we did was overlay these sort of clusters. So this patient might have hypertension, diabetes, and obesity. This patient, let's say this one over here, might have hypertension, diabetes, hyperlipidemia, and obesity, and potentially other complications. And so you'll see how this works out. But then we overlaid utilization. So we looked at the top 20%, which tends to be 80% utilization. Sure.
Are these unique patients?
Yes, they're all unique. You can only be in one group. So we overlaid utilization in the top 20% because I didn't show you on the first slide, but it's the 80-20 rule. 80% of costs accrue to 20% of patients. And it seemed like a good cut point for us. So we would call them high risk. We overlaid those and then started looking at our utilization. This is an 8-group model, 8-cluster model. And what you see, boxes are the patients. Red boxes are the top 20% users. And so we actually have 1,000 healthy patients. Now, personally, I'm an internist. That means they're inadequately evaluated. We can find some. But anyway, hypertension and hyperlipidemia, obesity and cardiovascular risk, so this is this. CV risk is hyperlipidemia, hypertension, and obesity. So then let's look at the next 4. Each red box is in the top 20% utilization. Diabetes and cardiovascular risk, chronic lung disease, depression, cardiovascular risk, renal disease, depression, cardiovascular risk. And that was by far and away, surprised us, the highest proportion of utilization. And then complex cardiovascular disease and depressed. So one of the things that jumped off the page was the prevalence of depression in the highest utilizing groups. And so we looked really closely at this. We focused on depression as a significant comorbidity. And it is associated, but we don't know whether it's cause and effect of utilization. The higher the utilization, the more likely people are to have depression. And there are predictors like cardiovascular disease, renal disease, and COPD. So these travel in the same sort of groups of patients. So this is another way to look at it. This is obesity, uncomplicated hypertension, hyperlipidemia, depression, hypothyroid, blah, blah, blah. Look at this. I mean, these folks have a huge comorbidity cluster. COPD, asthma. And if you're in primary care, you can't have 20 disease management programs. You need to sort of manage groups of patients. And so there's commonalities. Hypertensive patients who are overweight, who have hyperlipidemia, that's a cluster. We can work with them because the behavioral interventions are basically the same. Weight loss, exercise, adherence to medications, diet. And so it allows us to cluster services in a more effective way. And then, so we started looking at this. And we started also doing regression to see what other predictors could we identify. Now, surprisingly, the largest cluster of patients was basically the cardiovascular cluster. The highest risk of utilization was in the renal cluster. So compared to healthy, you had a relative risk of 5.47, likelihood of being in the utilization group. If you had less than an 80% adherence to clinic visits, you had 33% increased risk of using the emergency department. If you were from a zip code with 25% of the residents below the poverty level, it increased your risk of utilization by 25%. And if you had sickle cell, 1% of our patient population had sickle cell disease, 12% of our utilization. So an incredibly small population driving a huge amount of utilization. And we actually built out a sickle cell clinic just to address this. So we now have a sickle cell medical home, we have a medical director. She's also med-psych trained, which is really helpful because the opioid use thing becomes an issue in sickle cell very quickly. And, abuse, diversion, addiction versus pain. And so she's perfectly trained to sort of sort that out in a population that uses a lot of opioids. So then we have the team. So I'll concede I can't manage all of this stuff in patients, and I need a team. But sort of, why would I need a team? So let me give you an example. 31-year-old woman comes in. This is task-based analysis. 31-year-old woman comes in with dysuria. She's got a urinary tract infection and she needs some preventive care, pap smear, maybe a tetanus shot, and some behavioral counseling and a prescription. Actually, I see this patient and I think, what am I going to do with the other 10 minutes? I mean, it's very straightforward care. Well, let's make her 51 with dysuria, hypertension, and diabetes. All of a sudden, that task list starts getting long. And let's make her my typical patient, a 91-year-old with osteoarthritis, diabetes, atrial fibrillation, dementia, a history of high blood pressure, and she's got urinary frequency because she can't tell us about dysuria. All of a sudden, that task list is huge. And so how do we array a team around a risk-stratified population to make sure that sort of relatively straightforward, healthy people sort of get the level of service they need, and incredibly complex patients like this get the level of service they need? And so that got us thinking about sort of who does what on the team. And so we started looking at roles. So our CMAs and LPNs can do sort of basic things. We have standing orders for A1C and foot exam. They obviously do vital signs. They can begin the medication reconciliation process. They can screen for falls in vision. And they can do standing orders for indicated immunization. Cool. We have RNs. RNs are sort of education and home management, evaluation behavior, caregiver support, advanced directives. They can start that process. They can look at falls in vision as well. But the big thing that they do is care coordination. So our RNs are responsible for care coordination. So patients in the emergency department, the nurse is immediately alerted. Or if somebody's hospitalized, they're in charge of that care coordination process. And that pulled them out of the clinic, day-to-day clinic flow, and into sort of a new role of case management, care coordination within a medical home. We have PharmDs. We have 3 PharmDs. They are incredibly good at complex high-risk medication management, way better than I am. They run our Coumadin tracking system. They run our hydroxyurea system for sickle cell. High-risk medications, they're better than I am. They can also work through very complex medication regimens. They also do education. All of our PharmDs are also certified diabetes educators and smoking cessation educators. And so that leaves me, and I haven't figured out how I can sort of run this practice from my sailboat, but I have a couple things I have to do too.
Does that mean the patient's seeing all 4 of you on that visit? Does that get into scheduling issues, all of that stuff?
So you're guaranteed to see the primary provider in the LPN. The RN's running in the background. And I'll give you an example. So if somebody is admitted to the hospital, and under our transitional care management services, we get the patient within 2 business days of discharge. And the nurse, the RN, works through basically a checklist of, are you clinically better? Do you have what you need? Did you get your prescriptions that you needed on the way out of the hospital? Do you understand your medication regimen? And sort of those kinds of questions. If any of those flags for medication problem, they will schedule in with the PharmD before the primary provider visit. And so what we do is we sort of screen by phone, and then they route. And so we have specific transitional care management visits. We try to see every discharge within 7 days. We probably see about half of our discharge patients within 7 days. And we're sort of working on that process. But so what the nurse, the RN, is sort of responsible for is routing patients to the right place relatively quickly within the practice. So you may see everybody, or you may just see the primary doc and the LPN.
But you wouldn't come back 4 times to see.
Right, no, it's coordinated. Yeah, it drives you crazy if people have to come in 3 or 4 times. So this is our team, 4 APPs, 6 RN coordinators, 2 are allocated to sickle cell, 10 LPNs and CMAs, 3 PharmDs, 2 clinical support folks, 8 registration and scheduling, and then all the docs who are all part-time, a social worker, and an outreach navigator. And one of the challenges has been when we did regression and we started looking at our high users were also not coming into clinic. Remember that sort of if you don't come in, if you miss more than 20% of your visits, chances are you're going to be in the emergency department in the hospital. And so Bill Barry's our outreach navigator. He actually is incredibly good. He has incredible customer service skills. And I'm really worried somebody's going to steal him. But anyway, we actually stole him. His prior job was follow-up for randomized controlled trials. And you all know, sort of follow-up is critical to success to RCTs, right? You need to not lose people to follow-up. Well, we're not losing people to follow-up because of Bill Barry. A story about Bill Barry. Bill Barry comes down Shepherd Street to get onto Rutledge. The school guard, at the time, when he first started working with us, was one of our patients. And she hadn't been in the clinic. He pulls over, gets out of the car, walks over and says, Mrs. Jones, you haven't been in the clinic. I just wanted to stop and say hi, I'm Bill Barry. So now every time he sees her, he waves. She's very compliant. That's the kind of skills that Bill Barry brings. So we defined all the roles, and the sort of the bolded stuff is the critically important stuff, but there's a lot to do. And so somebody has to have primary responsibility for these major roles. And then we have team meetings. One of the things about teams is you have to get together. The leadership team gets together every week. Actually, the clinical delivery team gets together every week. 30 minutes on Fridays. On the resident side of the clinic, they have discussions about particular areas. So, for example, quality improvement in diabetes. Can we reduce our mean A1C across the population? Or blood pressure control? Or loss to follow-up? Or why did this patient get admitted despite the fact that we were sort of doing everything we seem to need to be doing to keep them from being in the hospital? And so they work through these problems every Friday. So then there's the process. So I don't know how many of you have been in primary care. I mean, there's a lot going on. There is paperwork that just sort of explodes overnight. Home health orders, rehab, nursing service, written prescriptions, medical records, all this stuff. And this is patient calls. We get over 36,000 communications from our patients every year. And it's actually going up. And we've actually encouraged folks to use MyChart. We need to be accessible. If we're not accessible, that patient's going to be in the emergency department on Saturday. So we need to open this door. But how do you route 36,000 communications? That's 180 communications a day coming into our clinic. That's three communications from every patient in the practice anymore. And so we had to look at our processes of management of flowing information. And if you think about sort of the workflow in the real world, this is the idealized workflow. You know, somebody registers, they're seen by our LPN, they're put in a room, they're seen by the provider. Provider, she might order like an x-ray, a test, patient goes out, checks out, and then reschedules, schedules follow-up. It's actually pretty straightforward, right? Well, but in the real world, you've got sort of all the pharmacies communicating in for refills and things like that. And then you have sort of prior authorizations for medications that sort of some payer doesn't want to pay for unless you jump through a hoop. And then increasingly, we're getting communications from the outside, clinical data. So A1Cs and glucose is measured at home, blood pressures at home, lots of things. And I don't know whether you saw there was just a recent RCT that talked about text messaging and improving compliance of cardiovascular risk reduction and blood pressure control. It was a randomized controlled trial published, it came out yesterday, I think it was on NPR this morning, but text messaging. So all of a sudden we're opening lots of communication highways. A lot of this is MyChart, but a lot of it is phone for folks who don't have a computer. We encourage folks to go to the library, use MyChart there. It's a better way to get to us, but then there's going to be text messaging. There's going to be lots of different ways of communicating. So that is what happens. The providers say, I don't want to do this. So we have to sort of route this in a way that makes sense across the entire team. So first we open up rapid access. We essentially guarantee that if you call in the morning, you'll be seen the same day, for whatever reason. And we stratify. So if somebody calls in and they say, well, I got a cold or a cough and I have a little fever, they'll come into rapid access. If they call in and say, well, I had chest pain yesterday afternoon, I don't know what it is, they'll come into a higher acuity clinic on the resident side. There's always 8 faculty members on the floor, roughly speaking, either seeing their own patients or supervising residents. And so there's backup for all of our rapid access is run by APPs, and our really acute care clinic is run by residents. So rapid access, we have to guarantee it. We had to figure out how to manage our messages. And so what we do is we have pools, and it's generally started actually where the call is received. Calls are routed in terms of, is this a refill request? It goes to one place. If this is a clinical symptom, it goes to another place. If this is sort of what are my lab results, it goes to another place. So we route them in a particular way. And we encourage folks to come in on MyChart because we know we can get to MyChart immediately. And MyChart, for those of you who don't know, is the Epic patient portal. We have standing orders, immunizations, standing order for A1C. If you come into rapid access and you have diabetes and you haven't been seen in 4 months and you have a cough, you're getting an A1C just because you're overdue, and it's a standing order. Refills, we have our opioid refill checklist where we look for things like a recent visit, the nurses actually do it, and the PharmDs now. We look for scripts reports, which is the state-based system. And then the LPNs initiate a medication history and sort of pen refills and other things in the record. Now, LPNs needed training on how to do medication history. So our PharmDs developed a training program where LPNs are actually certified in medication history. And they watch them, and then they give them a certificate. And then we shifted our ends to transitional care. Our PharmDs, as I mentioned, are in high-risk meds. Our team meeting works through the process. And then there's a new code. This is actually revolutionary. It's called Chronic Care Management. It is the first time ever that Medicare will actually consider paying for a non-face-to-face visit. And so we're starting to see even Medicare is kind of saying, okay, well, it all doesn't have to happen in the clinic. How do we migrate our payment system? But obviously the best payment system is going to be an ACO. So where are we? We have a huge analytic team. We should be seeing some impact, right? Well, it's really important to sort of measure that. Our data analytics team is like incredibly good. There's Patrick Molden, Jingwen Song, Zemin, Bill Barry's part of the analytic team, and Justin Morrison, who's a data manager, other folks. So how do we measure sort of how much of an impact we're having? So our CG CAPS, do you all know what CG CAPS is? It's a standard quarterly Medicare survey. It has probably 30 questions, and it asks about particular domains. So it asks about registration. When you called or when you checked into the visit, was the person helpful? When you called, did you get an answer back within the same day? When you came into the clinic, were you seen within 15 minutes of your scheduled appointment? Did the provider talk to you in a way that you understood? So CG CAPS is actually giving us a measure of patient experience. And then finally, would you recommend this clinic to your friends? So that's a measure of sort of the patient experience. We have others, and we've put together actually a sort of community advisory board for UIM, which has been incredibly helpful, getting feedback from our patients. So what about quality measures? So there's a gazillion quality measures out there. And so we've started slowly. We're looking at blood pressure control. Not surprisingly, more than half our population has hypertension. We have a little less than 3,000 patients with diabetes and immunizations. So those are the quality measures that we're working on. And then utilization measures. Lower cost. The low-hanging fruit is preventable utilization. So hospitalization, rehospitalization, ED visits, they're huge cost drivers. Just to put it in perspective, the average emergency department visit is a month's rent. The average hospitalization is a year of daycare. These costs are huge. And so these are sort of, from our perspective, low-hanging fruit. We can have an impact on these. And then how do we do it? I mean, our team knows, Our quality measures are really about the visit process, they're about pre-visit planning, they're about team meetings, and about outreach. Our CG CAPs, we have to be available, responsive. We're building our relationships, we're engaging patients. And then utilization measures. We know risk stratification, we know care coordination, transitional care, and chronic care management, those are the tools. So we're doing pretty well actually in CG CAPs. The faculty clinic is actually is among the highest patient satisfaction within MUSC. The resident clinic has a sort of significant way to go. And not a small amount of that is our systematic discontinuity. Actually, their patients want to see them, and it's really hard to do. So we've done things like every 4-month visits for folks. And you come in between, you see one of the team members. But it's still sort of a work in progress. There is a patient-centered medical home CAP survey, not required by MUSC yet. So actually, this is 100% sample. And for us, that would be about 5,000, maybe 6,000 patients. So MUSC's not been in a real big hurry to embrace that cost of surveying 6,000 patients a year. But I suspect it's coming. And it's in depth about PCMH type services. Do you know who your care coordinator is? If you ever needed to see a social worker, were you able to do it? And this is quality data. So this is just percent of UIM visits with a controlled A1C. We started out in August 2012. About 3/4 of the time we're in control. We're getting up there. But this is only patients with visits. So now actually we're backing out to, what about our whole population? And those data we're looking at, but we're making progress. It's not as rapid as this has been. So folks we see, when we focus on them, we can get high quality measures. The folks we don't see are the challenge. And a little competition doesn't hurt. So this is the resident practice, the faculty practice. This is my part. Okay. Anyway. So you can see the residents really face some challenges. They face much more social sort of barriers to care than we do. Transportation is a huge barrier, followed quickly by sort of cost.
So Bill, who's the leading pot there?
Who's the leading pot is, it's Kim Davis. I think she juggled the numbers, but yeah. She's the clinic director. All right.
Yeah, can I just ask, so
Sure.
the resident clinic are people who really seem more emergently or...
Actually, they have continuity panels as well. Each resident has roughly 60 or 70 patients. The problem is that they don't see their doc every time in the resident clinic. Actually, to be truthful, the RNs in the resident clinic are the agent of continuity. These patients know their RNs incredibly well. And these RNs have been there for 25 years. They're incredibly dedicated to this patient population. And that's probably why we're able to maintain a resident clinic. Because actually the nurses are the ones who sort of break down barriers and get stuff done. And this is utilization. So the green line is, So what we're looking at here is emergency department visits by ambulatory care sensitive conditions. And ambulatory care sensitive conditions are exactly what they sound like. If you provide high quality ambulatory care, these conditions are sensitive to intervention. So it's things like congestive heart failure, COPD, asthma, coronary disease, pneumonia. Non-ambulatory care sensitive conditions are things like cancer, trauma, and total hip replacement and those kinds of things. They're not sensitive to ambulatory care. They're going to happen. And so the green is non-ambulatory care sensitive. The what looks like orange is ambulatory care sensitive, and then this is the total. And notice, that's 450 ED visits a month. So this utilization drop is about 25%. It's down over 100 ED visits a month. What is incredibly cool about University Internal Medicine is we have such high utilization, we can see change that, for example, lower acuity clinics can't. And this is hospitalization rates. This is ambulatory care sensitive, and you can see non-ambulatory care sensitive hospitalizations are flat. We wouldn't have an impact on those, but we have an impact on ambulatory care sensitive conditions. And that's a p-value is for slow change. This is an interrupted time series design, and it's over, looks like 4 years. So what's that mean in terms of cost? Well, it's really hard to measure the cost of something that didn't happen. On the other hand, economists have dreamed up some incredible models. And Patrick Malden many of you know, is an economist. So he dreamed up a model, actually. And so he used estimated costs based on predictive models. So for example, the way economists predict stock prices, for example, or commodity prices. So for example, corn. The yield of corn this year is probably dependent on the weather this year. It's probably also dependent on rainfall last year and other conditions that influence projections. And so what we were looking at was the actual monthly cost, and we worked with the hospital on, this is all acute care utilization, and then projected it out. This is the interrupted time series design. And then these are the 95% confidence intervals. And so what we see is basically the projected cost has dropped by, it looks like, $1 million a month. Now, it's probably an overestimate. These kinds of cost projections you can't do for very long because of the number of intervals. But even if it's $500,000 a month, it's a significant cost reduction. And so this is called autoregressive integrated moving averages, or REMA. So 500 to $1 million over the last 6 months, and these are all offset. They more than offset the sort of grant that we got from the hospital to bring up the patients at a medical home. So the annual incremental cost is $8 a visit. The reduction is, say, $500,000 a month. It more than offsets cost. And that's under a fee-for-service. This is under fee-for-service. So our cost per encounter has dropped. Our physician collections haven't changed under fee-for-service. Our hospital collections have gone up by $13 per visit. So, summary, we actually think we kind of hit the AAA. We have improved the patient experience by CG caps. We've improved quality, at least in the measures that we've looked at so far, and we're looking at way more measures in the next year to two. And then we've reduced costs per patient. And what you see in ACOs, accountable care organizations, and there's 32 pioneer ACOs in the United States, all authorized by the ACA, is significant improvements, savings, 87, 96 million, 128 million per ACO on average. Clinical quality scores going up, this one, and then this one to this one. And then the patient experience going up. And they depend on PCMH, patients out of medical homes, to sort of make the ACO profitable. So, just to summarize, we have a leadership team. It's an interprofessional leadership team. We know a lot about our population, and we can risk stratify them. We have really worked at sort of developing a highly functional team. It's interdependent. We actually have a retreat this Friday, and one of our challenges is we're going to break the hierarchy. So this used to be the physician-centered medical home, right? It's now a patient-centered medical home. And so sort of hierarchies that historically have been present in primary care, and especially hierarchies in academic health centers, we have to compress them. And so we have a retreat this Friday, and we actually, at our first retreat 5 years ago, our registration folks said, oh, wow, that's the doctor I've been talking to on the phone. He's actually not a bad guy. You know? Now, we are actually a cohesive team. And so Friday, we'll be sort of working through the issue is high reliability. And so how do we make sure that every time we touch a patient, we do the best thing we can for them? So that's the high reliability component. We can do a lot of this stuff, but can we do it every time? And that's the challenge that we're going to be working on in the next year. So, and then we've re-engineered care processes. It's incredible how much we are dependent on the electronic record, and how our workflow has to adopt to that, and the record has to adopt or adapt to what we're trying to accomplish. And then finally, making sure you measure, because the letter example is a good example. If something doesn't work, you want to know quickly. And now we're trying to teach this. So now we for the first time, have two actually fourth-year medical students starting to rotate through, and Candace is one of them. She's finishing the rotation. We have APP trainees, mostly RNs, We're looking to bring in PAs because we have a mixture of advanced practice providers. And then obviously we've been working with the residents, but the residents are learning teams. And it's incredible when you're going to a resident team-based team meeting, the nurses run it. The faculty don't run it, the residents don't run it, the RNs run it. So, it's kind of cool. So, editorial from New England Journal, leading clinicians and clinicians leading. The challenge in healthcare reform is this is not a C-suite problem. You can manage healthcare from the C-suite if you just do volume. I buy a new MRI machine, I project how many times I use it, I project my margin, and I move forward with it. How do you manage improving quality and lowering cost and improving the patient experience from the C-suite? It's impossible. You can't, this is not a top-down strategy. This is a very much bottom-up strategy. So, the promise of global improvements in quality or cost. How do we do it? Successful implementation depends on local factors, effective care teams, and good management of local operations, clinical microsystems. The clinicians are going to drive this. So, thanks for listening. We got 15 minutes. Good luck.
So many of your, I really enjoyed this presentation, thank you. So many of your conditions that you're treating are really back to behavioral risk factors, smoking, alcohol, depression, you noted. Have you thought about having a dedicated behavioral support within your team?
Absolutely. We've been thinking about it for 3 years. So where I was in North Carolina, in the community care in North Carolina, they had sort of co-located mental health providers within specific patient-centered medical homes. And just to give you an example, 15% of our population is depression or some other mental health condition. 50% of our admitted patients have it. 85% of our readmitted patients have a comorbidity. And in North Carolina, we used to call this the lower right quadrant. So complex psychiatric disease, complex medical disease. And so that's the quadrant where the utilization is huge. And I agree. We just have to figure out how to fund it. We tried one recruiting strategy last year. We're looking at another one this year. Tamia Martin, who runs the sickle cell clinic, is med-psych trained, so she's a resource within the clinic. But you're right. We actually need to integrate it more thoroughly to have an impact on us. Yeah, Jihad. Thanks for coming. You know this stuff.
I wish. I only mentioned this because you mentioned my chart like 3 or 4 times.
Yep.
So we're looking at using my chart, as you know, for patient recruitment, research, and volunteer
Sure.
research. So we're looking at barriers to that and barriers to adoption to my chart.
Mhm.
And we have early work showing, you might expect it's lower adoption and lower socioeconomic.
Right.
So I'm wondering if also you look within your cluster, you probably have,
Yeah.
within your clusters at adoption of my chart and whether that would be interesting.
So it actually surprised us that older age was not associated with reduced mind-chart adoption.
That's right.
But what was poverty and lower incomes. Our community advisory board has been sort of advising us on, well, in your sort of orientation to the clinic, why don't you suggest that folks go to the library and use MyChart? Because there's free computers at the library. Or cell phones, smartphones. Everybody in UIM on the resident side has a smartphone. You want to communicate with a sickle cell patient? Smartphones. They're all, and they used to actually, so I supervised in the sickle cell clinic, and I would pull out my flip phone, and they would laugh at me. It's like, what are you, from the 1920s? But, so smartphones are another strategy, and I was mentioning earlier the study in Australia of using smartphone communications, routine text messaging to improve cardiovascular management. So I think we're going to need a lot of different strategies. Folks who can get to a library, folks to get access to a computer, better access through smartphones or other devices, and then finally sort of kids. So in my clinic, it's mostly older folks. The folks on Kiowa, they're on MyChart all the time. The folks on sort of Seabrook, yeah, no problem. My folks in North Charleston, I got to work with their kids or their grandchildren to sort of get them access. There are lots of older folks who never used a computer, and it's intimidating, especially when you hit the button and nothing happens, right? So anyway, I think there's going to be a cohort effect, but this current older cohort is going to be hard to get into. Yeah, but I agree. I mean, for randomized controlled trials, using MyChart is great because you're going to get folks who are sort of interested in research. So, but you're going to get a skewed population. What was that?
We don't want that.
I know. Yeah.
Cindy did it first.
Yes, ma'am.
Thank you, that was great. I'm curious about your community advisory board, your patient advisory board, who's on it, and how they work with the clinical team.
Yep. So we actually handed out an invitation in the waiting room. We had 60 folks within 3 weeks who wanted to join the community advisory board. And we just kind of arbitrarily chose 10 to reflect diversity, age diversity, diversity of race and ethnicity, and diversity of sort of conditions. And so we just bring them together for an hour and feed them lunch and, pay for their parking. And they've been incredibly helpful. So the first thing we walk in and we think, they're gonna fry us because we're not as accessible as we want to be. And we found in multiple focus groups, our impression of what we do is way different from their impression. They think we are incredibly accessible. What they find the challenge is, but I want to see my own doctor. I don't want to see this person. So we've identified some of those barriers. I'll give you another example. We had a focus group in sickle cell. And we thought, we really alienated the sickle cell population. And in our focus groups, we heard, well, actually we prefer MUSC because it's worse everywhere else. At least you guys know what sickle cell disease is and you have a protocol. And so that was kind of reassuring to us because we weren't sure we were going to succeed in building up the sickle cell program. So we've only had 2 community advisory board meetings so far, but our goal is to sort of for them to help us. One of our advisors, who is very outspoken at the meetings, actually redesigned our orientation flyer that we give to patients. Said, it's way too busy. I want to take a stab at it. I said, go for it. And so she sent back a sort of back and front three-fold orientation that was way better than what we did. We stuck in everything, totally irrelevant stuff. She said, this is what we need to know. It's been spectacular. So, yeah, we're hoping that will continue to inform what we're doing. And another way to test what we're doing. Yes, Ron.
2 points. One, pet peeve with respect to a behavioral health person.
Yes.
Just because they have a mental health degree doesn't mean they're versed in evidence-based behavioral health, which is an entirely different type of thing. And we never look at that. So if you do get somebody, make sure you get somebody who's got the appropriate training and not just somebody who likes to talk about
I know where you are, man. I think you might interview that person on the way through.
I would be happy to interview them.
Yeah.
The other thing is, and this is important to Les and other people, if you want my chart update, there's a couple of cool ideas, but one thing that could be done right away, which is what we did for satisfaction. At the Prime Victim Center, we have to have patients fill out a certain number of satisfaction. One of our student volunteers decided to make that their College of Charleston paper, and we went from 50% to 100%. Actually, we went to over 100%. We have to figure out how that happened. In terms of patients completing the satisfaction, simply by that person or a team of volunteers sitting in the waiting room and saying, hey, can I help you get on the satisfaction survey?
Sure. Yeah.
And that's one way to get my chart updated, I think, because it's a pain in the neck if you don't just, even if you have a scanner, using my father as a perfect example of an intelligent guy who can do nothing by himself. If somebody says, hey, do this, and then you have it, then go use it.
Right.
But the first point is just, we can't just say, well, let's give a behavioral health person, oh, look, it didn't work, they didn't
Right.
reduce smoking or anything.
Right.
Because you need to get somebody appropriately trained.
Sure. Oh, I would totally agree. With respect to the second point about my chart sign-up, we actually assigned Bill Berry to the waiting room, so he's our best customer service person. He could sell used
So I'm
cars.
sure you guys have everybody on.
Well, but it's not generalizable. We can't put an FTE in the waiting room. So what we need to actually do is integrate it into the registration process.
Right.
So if you want to register for my chart, let me just do this. The challenge is with 200 patients a day coming through the clinic, it's flow. And so we're still under fee for service. Were I king, I would basically say, don't worry about flow, make sure everybody signed up, and we're going to manage half of these folks by my chart. Because lots of this stuff that we currently use as visits, we can substitute with other communication strategies. But under fee-for-service, we still have to pay the bills. And so that's where I would put it. It would be a routine part of registering into the clinic and then, coming in for visits. Or be done by email. Yes, sir.
Just want to point out that registration into my chart doesn't mean that you're using it.
Right. Right. It's just the first step. Yeah.
That's a different behavioral discussion. So it's worth it to them for cost to them not to use it. I mean, just behavioral economics is sort of clear. If they're not using these things, they're not reinforced, they're not punished, they're not just
Right.
changing contingencies, change to use.
It's not behavioral economics, we can get the providers to visit too.
Yeah, really.
That we can control.
And just one second. One of the key things we got from our community advisory board was MyChart use. Basically, they want to tell patients that if you use MyChart, it is a reliable way of getting to us quickly. So that it's in their best interest to use MyChart because it cuts through the layers. I mean, there's like 12-minute waits on our scheduling phones, and people just hang up. It's abandoned. Where MyChart's through and in the clinic, into clinically relevant people, like right away. So yes, sir.
You had mentioned sickle cell driving a lot of costs in the sickle cell clinic, so have you seen any?
Yeah, we've seen a reduction of about 25 to 30% in emergency department visits. What was interesting about the sickle cell population is it's a small population to drive utilization. And so by identifying those folks, bringing them into clinic, make sure we have a relationship with them. Folks now actually, if we, for example, Friday afternoon, we are closing the sickle cell clinic, we will get pushback from the sickle cell patients because we're not as successful as we usually are. And they really hate to go to the emergency room. We have individualized care plans within MyChart that we can activate right away that have dose-adjusted opioid management. So, you walk into the average ED, they'll give you 3 rounds of 2 milligrams of Dilaudid. 6 milligrams of Dilaudid in the first hour in our sickle cell crisis plan. They may get 4 rounds. They'll get 24 milligrams of Dilaudid in 4 hours, compared to 6 in the entire emergency department visit. So the care is very sort of focused on their needs, their opioid tolerance. And it's a safe clinic. We use continuous pulse monitoring. We have 2 nurses watching 3 patients each. We watch we do pill counts, we do all this sort of things to look for abuse and diversion. And they're cool because it's a way better experience and they have a relationship with the providers. So yeah, we've driven it down. It's a smaller population. We can't see hospitalization reductions just because it's only 100 patients, of which probably 20 are really sick. But we've seen it in the emergency department visits. Cool. Well, thank you very much for listening.